I am Dr. Irene Gullo and I am a fourth-year fellow in pathology at Hospital São João in Porto, Portugal, as well as a PhD student at the Faculty of Medicine of the University of Porto and at Interview-Irene in Portugal. We recently published our study in gastrointestinal endoscopy entitled The Phenotypic Heterogeneity of Hereditary Diffuse Gastric Cancer, the report of one family with early-onset disease. As the title of this study forward, this is not just a report of another family with hereditary diffuse gastric cancer. Actually, in the description of this family, we try to show the heterogeneity of this syndrome from the clinical and pathological point of view. Hereditary diffuse gastric cancer is a hereditary gastric cancer syndrome and is characterized by multigenerational diffuse gastric cancer and lobular breast cancer. In up to 40% of cases, the genetic cause is a germline pathogenic alteration on the CDH1 gene, although other genes have been recently implicated. The clinical course of the disease is unpredictable, and the only curative approach is a prophylactic risk-reducing gastrectomy at young age. In the CDH1 family described in this paper, the proband was an 18-year-old male and he died from widely aggressive metastatic disease. By contrast, the majority of the CDH1 carriers from the family did not yet present with the disease, including his 83-year-old grand-grandmother. His sister was submitted to total gastrectomy at the age of 14, and she is the youngest patient reported to date to be submitted to total gastrectomy after a negative workup. As you can see in this image, the proband had a subcardiac large ulcerated mass. Histological analysis from endoscopic biopsies showed a purely differentiated gastric cancer with bizarre and pleomorphic cells. In this paper, we emphasize the role of the pathologist in reporting such a poorly differentiated phenotype in this hereditary context because it is suggestive of advanced disease and should prompt urgent clinical intervention. The picture is completely different in the case of early intramucosal lesions, where we can see these bland synerine cells invading the lamina propria. These lesions usually spread throughout the stomachs of the patients and rarely progress to widely invasive carcinoma. In this context, our questions were: what is the reason of early lesions to progress to such an aggressive phenotype? Why is the clinical presentation so different between one individual and another in the same family? We investigated these questions in a previous publication, and here we were able to confirm such results. Early lesions do not proliferate and do not express p53, while aggressive lesions, as the case of the proband of this family, have a high proliferation index and overexpress p53. In this case, we also found the expression of phosphorylated SRC and STAT3 in the tumor cells of the proband, and these are biomarkers of oncogenic signaling and of epithelial to mesenchymal transition. Finally, we searched for H. pylori infection, and almost all patients were infected with KG-positive strains, with the exception of the young proband sister. In conclusion, hereditary diffuse gastric cancer is a heterogeneous disease with great variability in clinical behavior, morphological appearance, as well as immunophenotypic and molecular profile. The progression from indolent lesions to an aggressive phenotype is probably caused by multiple environmental, genetic, and molecular factors, whose role remains unclear, deserving further investigation. We would like to thank all the co-authors that collaborate in this study and the multidisciplinary team at our hospital that is essential for the correct management of these patients. If you have any question or if you want to share another amazing case with us, please do not hesitate to contact us. Thank you for your interest.